Nice to see you guys. Thank you for coming, my friend. Hello, good morning and good evening. I'm Dr. P.Y. Cho. Today I will moderate this webinar with my partner, Dr. Junior Tu here. Today is our 114 ICC webinar. We are so happy to have Professor Uilyong Li here to be with us. Professor Li is a highly qualified specialist in oral and maxillofacial surgery with an extensive background in both academia and clinical practice, primarily centered in South Korea and abroad. He earned his DDS at 2002, master degree 2006, and a PhD 2019 in oral and maxillofacial surgery, all from the Seoul National University. His doctoral thesis focused on the three-dimensional printed implant for maxillofacial reconstructions. All his clinical training, including his internship, residency, and fellowship, was complete at the Seoul National University Dental Hospital. Professor Li holds certifications from the Korean Board of Maxillofacial Plastic and Reconstruction Surgery at 2006 and the Korean Board of the Oral and Maxillofacial Surgery at 2017. Since 2011, he has been an associate professor in the Department of Oral Maxillofacial Surgery at the Chang University Hospital in Seoul. His international experience includes serve as a visiting scholarship at the Sleep Surgery Clinic, Stanford University from 2019 to 2020, and working as international cooperative doctor and maxillofacial surgeon at the Ethiopia Federal Police Hospital in Addis Ababa from 2006 to 2008. Besides, he is very active and enthusiastic to join the international CLAM mission as well. Today, Professor Li's topic is the revision orthodontic surgery and the revision facial contouring surgery. We have invited two very good and experienced orthodontic surgery surgeons in this panel discussion. First one, our old friend, Professor Watanabe Yurikazu from Tokyo Metropolitan Hospital. Hi, Professor Watanabe. And the second one is our old friend, good friend from Bangkok, Thailand, Professor Saron as well. And Professor Saron is coming from Naresuan University, Bangkok. So can't wait to learn from Professor Li. So Uilyong, please.
Hi. Thank you, Dr. Introduction about me and every doctors and my colleagues. Thank you for joining this amazing international craniofacial Chang webinar. And it's my truly honor can give a lecture in here. And so today my topic is revision orthognathic surgery and contouring surgery. Can you hear me? Can you clearly hear? Okay.
Yes.
Okay.
Yes.
Okay. Chang University Hospital in Seoul. There are more 800 bed. Actually, it's not a big hospital. It's a middle-sized hospital in Seoul. And I met a great Taiwanese surgeons, Dr. Cho, Dr. Guo Jin Song in Hanoi. We had a really great time in Hanoi, and these meetings and the Dr. Cho, we know each other in Hanoi, yeah. And today my topic is the background onion bag method. I will tell you what is onion bag method. And reposition and the revision orthognathic surgery, and finally, patient-specific distractions. And background, why the patient want revision surgery? And now the number of people who want revision surgery after facial contouring surgery or orthodontic surgery increasing worldwide. This is my patient is from all over the world, Canada, and the States, Australia, Malaysia, Bangladesh, Hong Kong, and Kazakhstan. It's really various Asians and Indian and a lot of ethnic groups. Why I think this is usually till now the craniofacial deformity is like class 3, class 2, or cleft-driven palate or pure lobang like that. But nowadays is surgeries like orthognathic surgery or facial bone surgeries, a lot of deformities we can see. And you know what it is? The mandibular bone, the one plastic surgery in Korea, they displayed this reject hospital lobby. This is human bone pagoda. Very is very astonishing. As you see, a lot of the bone defect after the surgeries. This is after the orthognathic surgeries. I don't know what happens, but happens very frequently in Korea and all over the world. So why? I think the conventional method for mandibuloplasty using oscillating saw is very difficult to manage. So actually, I don't use this one because it's very difficult to manage. So the using the oscillating saw during the mandibuloplasty and rejections and the nerve damage can and we cannot see the nerve canals like this, and asymmetry and the most frequently the concern of patient after facial burn is like depressions, bumpy, not is the we call I named this phenomenon omega shaped because it looks like the after the rejection of the mandibular body, it is frequently happened, and after rejection of the salivary gland, the submandibular gland ptosis can happen like this one because it looks patient more aging. Yeah. And three, a patient complain about the obtuse facial lines. There is no definite margin. There is no kind of the boundaries. There is no angles like depressions. And after two one to the short shorten their face, the doctors move up the maxilla. So after that, the up this is one of the most complaint of the patient, and as a consequently, the lower teeth lower so and the excessive clockwise rotation or max the mandible is so setback. So and after because of this one, the double chins can happen, and usually this the facial profiles is the patient impression is more passive and more sad, and bone defect should be augmented. When bone defect should be augmented, and we should put something to reconstruct and manage these problems. So there are many materials for augmentations, but I think for the good result, the materials can be 3D printed. So we can use titanium or methyl methacrylate. This is bone cement for 3D printing. Uh, I used titanium for the reconstructed facial bone. So I published this paper in the scientific report. Long term result after using after titanium implant in mandible, maxilla, in many places, and so the result is very good. And this patient is augmented using titanium implant. I augmented the chin, I augmented the angle, also angles and the chin. It's very good result. It's a great result with the titanium, 3D printed titanium. But nowadays, patient more want augment their mandible or their maxilla, their zygoma with their own bones. So there is I used, as I told you, I used the onion bag method. Using the onion bag method with the autogenous bone, I can augment the mandible very with a very great result. So from now on, I will tell you. Actually, this onion bag method is I think is one of main topic of my lecture. The onion bag method is a 3D printed PCL shell plus autogenous bone method. And I will tell you the mandibular angle and chin reconstruction using onion bag method. The PCL, polycaprolactone, is a biodegradable polyester. PCL is degraded by hydrolysis after S ester linkage in physiological condition, such as in the human body. So that means PCL is resolved in our body, and it can be 3D printed. And this a 25 years old girl come to me. She want to reconstruct her mandible using her own bone. She didn't want to put any titanium or bone cement and things like that. So I designed the angles, and I printed the piece using PCL, just outer skeleton. It's not the solid, it's just outer shells. So, and I will put out, and I harvested the bone from her iliac site, and I crushed into the particulated marrow and corticulated bone, and I mixed with some autograft, the allograft, and I mixed with the BMP. So this because of it looks like an onion bag, so I call it this method is onion bag method. And then I fixed with the screws. And nowadays I don't use the titanium screw. I use the resolvable screws. And this is the before surgery. This is immediately after surgery. There is just we can see the ground like the grafted bone, but just 8 months after surgery, we can see the really perfectly regenerated bone. So this is the CT scans. This is 4 months after surgery, and as time goes by, the cortical bone is thickened. And interestingly, the border between the original bone and newly regenerated bone, the margin is resolved. Actually, there is no need of this margin. So and this is the 8 months after surgery. We can see the well defined mandibular angles. This is 5 years and 9 months after the surgery, and the regenerated bone is very stable. It's not reserved. It just it maintain its shape. And this is left side. This is well regenerated bone is very stable. This is a 4 year 9 months after surgery. Also, she had a well-defined mandible angle. This is the onion bag method. I use this method for the angle, chin, and zygoma in every yeah, in all of our in my patient, and the result is really good. From now I will show you some cases. And this patient is a girl, and she also complained of the two pointed chins over rejected mandible. So this is the design of PCL. PCL, this is out the PCL. This inside the pink is bone, regenerated bone. Is the left side and right side. And also she want to the zygoma reposition, and she had before the zygoma reductions, but she want restore the original shape of zygoma. So I will tell you later. I use the patient specific plate for the for reposition the reposition the zygoma. At first I using this guide. I make a hole here, here, and here, here, and I remove the this guide, and I cut it. I cut the zygoma, and there is a hole already. I make with this guide, and the this patient specific plate has is position information of zygoma. Just I put the screws here, and the zygoma, the rejected zygoma will go to the our planned position. And and so this is the after 7 months after surgery. There's the really well regenerated bone. We can see regenerated bone, and the zygoma is well positioned outer reposition as before zygoma reductions. And this is the soft tissue change before and after the well defined mandible angle we can see. And also this is left side, the mandible angle, and also we can see the elevated zygoma body. Yeah, this is before and after. The angle is well reconstructed. Also, the depressed zygoma is well augmented. As the right side, same. And angle is well, the depressed area is well augmented. Yeah, this is another patient. This is a 32-year-old female, and she complained of a chin deficiency. Actually, before this surgery, she was a class two chin deficiency. Even after the Tujo surgery, the chin advancement, also she complained of very small chin. So I design the PCL like this, and I usually I design the guide because the exactly position of the PCL is really important. So I design the PCL, and also I guide. So this is after the augmentation. And she had a really big iliac site, so I can iliac bone, so it's easy to harvest the bone. Usually I mixed with 3 or 4 of aura graft. So usually I can reconstruct all in big defect. Big defect. This is before and after the surgery. The chin area is really good, and the angle also we can I can the reconstruct the angle also. This is the CT scans. This is immediately post-op, and this is 3 months post-op. This 6 months post-op. As you see, this is 6 months after surgery. This is a newly regenerated bone. The cortication is very good, and inside the very interesting thing is the trabecular pattern, the marrow pattern is really same as the original bone. Yeah, it's very interesting. Yeah, very interesting. So it's amazing. It's 6 months after surgery, really big amount of bone is really well regenerated. So this is also 32-year-old female, and she complained of over rejected mandible. And this is maybe after the mandibular rejection, the unwanted resorption was happened. So this is very, very not aesthetic, the shapes. So this is, I use the onion bag method. This is the right side, this is the left side. After the reconstruction, this is maybe 6 months after surgery. The over rejected, very, very unaesthetic chin is very well augmented, and on obtuse facial line is very defined mandibular lines, and also left side also. This is very, very, very patient that dislike this kind of things. It looks more sagging, it looks more aging. So the patient to
Patient, what?
to yeah,
Yeah.
so it's very well reconstructed. And she is a 21-year-old girl, and she told me that do something for me, please. And actually, she is very beautiful. She had really nice skins, and the eye, and is very, very beautiful, but is very awful mandibular lines. And she had maybe is as IVRO before, and too much rotations. And yeah, it designed like this after the surgery. This is before and after the surgery is much better than, yeah, before. This the all the mandible is reconstructed with this autogenous bone. And she is a 23-year-old girl, and she complained of chin, so the pointed chins, and over uh, rejected Zygoma, and she want to reconstruct the angle also. So I designed Zygoma and chin. This is a before and after. The angle, chins, angle, and the Zygoma is well reconstructed. This is a left angle. This is after reconstructions. As you see, this is a panoramic view. This is before, after. You see a really well generated bone. We can see this is before and after. Very, very beautiful bone regenerated. So this is a before and after. The well, I think is more symmetric, and yeah, maybe it depends on the doctors. Some doctors can say this is more beautiful, but patient like this one. So I respect the patient want. So yeah, I reconstruct like this. So yeah, the before surgery, there is no very obtuse line. There is no definite line, but after the surgery, the angle we can see, and there the double chin disappeared. The chin line is very nice. So the left side also, there is a definite angles, and the chin line is very beautiful. Yeah, and yeah, and maybe one of you so have questions. If the patient is more than 50, or if the patient old, if the bone regeneration can be possible, yes, I will show you. This is a 52-year-old female patient, and she complained of the facial asymmetry. The right side is good, but left side is rejected more than right side. So because of that, there is a big depression on left side. So this is the facial photo. There is no big depression here. So I designed the PCL and guide. This is maybe 8 months after surgery. 8 months after surgery, the left mandible is really well regenerated. So I will show you the the coronal cut of the regenerated bone here and here is really well regenerated. Here, here, yeah, here. And I have another patient who is more than 50 years old, but I think in female patient, it's good to before menopause, yeah, before menopause. If the yeah, before menopause, there's no problem of bone regenerations. And this is okay. We will see the the soft tissue change is before and after, before and after. Yeah, this is before and after. This is before and after. Very well defined the mandibular angle lines. We can see. Yeah, and somebody want to know how the regenerated bone strong. So I will show you. This is a 65-year-old female, and maybe is after menopause. Yeah, after menopause, and is she want full implantation, but there is no bones here. The nerve is here, so it's impossible to install the long implant. This case is published in this journals 2022, and I used the PCL and bone from her chin. So this is after the bone graft. And then after 6 months after, I installed the implant, and actually the another prosthetic doctors make her teeth. This post-loading after 12 months is no problem. So I can say the regenerated bone is strong enough to support dental implant. Yeah, this is from now on. I will show you the cases, only cases, not the design. This is a girl, and she complained of over rejected all the mandibles, so I reconstructed all her mandible, and this area is well regenerated. So and I think using this panoramic view, we can see directly the regenerated bone. You can see here, this is a newly regenerated bone. I cut her, during the operation, I cut her chin. I lengthened a little bit. And then I reconstruct her mandibular angles and the body. So, and she is a 40-year-old girl, lady, and she is over rejected chin and mandibular body, and so you can see the double chins. And I used the onion bag method to reconstruct her chins. Is 47 months after. This is pre-op and post-op. It's very well regenerated bone, and usually the most frequent patient complain of this depression. I think many of you doctors have the same experience after the chin advancement or the reject her mandible. There can be depressions here. I call it the omega phenomenon, and I can handle this omega phenomenon using the onion bag method. And this depression is very well managed. This is a panoramic view. The pointed chin, usually the problem of this depression is because of this area bone is defect of this area. So I reconstructed this area. You can see the before surgery there is very pointed chin, but after that there is a round chins. So it's very well regenerated bone. We can see. Yeah, this girl is a 38-year-old girl, lady. She complained of her chin is too short and over rejected mandible, and she want to restore her zygoma also. This is after surgery. As you see, the pointed chins and the change it to the round shapes. and also the depressed the zygoma is well augmented, and the chin line, there is the ptosis, the mandibular submandibular gland ptosis is disappeared after the reconstructions. This is also and the zygoma is well augmented, and I think that some of patient like this kind of zygoma, but some patient like this kind of zygoma. It depends on the patient preference. So this is after the surgery. You can see the well regenerated bone, the mandible, from the angle to the body. Yeah, and this method is very good because immediately after the surgery we can see the effect. Before the bone was regenerated, because of the PCL PCL is rigid, so immediately after surgery we can see we can see the result. So this is 2 months after surgery, and she had a very well defined mandibular angles. And she complained of these depressions. This is after surgery. It's very rounded chin. And this is a submandibular gland ptosis, and double chin is well well managed. This is panoramic view, is a well-generated bone is here and here. So I want to show you this method is very reliable and the stability. So that's why I'll show you the result of the panoramic view. And this I will go to quick. This is a mandible angles before surgery and after surgery, before surgery and after surgery, the well regenerated bone angle area. And she complained of 2 rejected chins and double chins here. And after the surgery, double chin is well managed. And yeah, and also this is maybe this is 1 millimeters and 3 millimeters. Using this onion bag method, very delicate reconstruction can be possible. Yeah, and she is also complained of the double chins. Double chins is managed, and there is a well regenerated bones here. And the 2 pointed chin depressions, also this double chins well uh, managed, and this is good shape of the regenerated bone here. And this is 24 years months after the surgery. There is no there is very obtuse mandibular angle lines. This is very well defined angle lines. Yeah, and this girl is complained of the too much grinded zygoma. So I used this onion bag method to apply to the zygomatic area. So this is very flat zygoma. This is after that there is well augmented zygoma. This is very flat. And after that, there is the zygoma area is well augmented. So usually there are 2 kinds of zygomoplasty. One is just zygoma positioned inside, and some doctors using just grinding. So this is this patient have a grinding method. So for this for to reconstruct this zygomatic defect is impossible to reposition. So I choose to this bone graft material. The onion bag method is very well regenerated the bone in zygoma. Also a left side. Yeah. Now the study now is being study is in on is doing. Now I calculate the resorption rate and the density and volume. Actually, is now ongoing, but so I can say the resorption rate is less than 20%, and more than 80% of patient is the resorption rate is under 10%. So uh, so the volume is just remain okay. So okay, I'll write a paper about this study, and maybe you can see the paper and the exact number of the density and volume and the resorption rate. And next my topic is zygoma repositions. And after the zygoma surgery, a lot of patients complain of cheek area depressions and ptosis, ptosis, ptosis. So I think I think the aging process is kind of upside down of the the egg. This is the young face egg. This is old face egg. The sagging because of sagging. I think I think the zygomoplasty is intentionally upside down of the egg because of this area. The zygoma bone is really important in our face, but intentionally the 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 reduction of the zygoma bone. Some patient can be very satisfied with the result, but a lot of patient is complain of the after the zygoma surgery. And I will yeah I one of my practice is zygoma reposition in Korea. In Korea is very interesting. It's like a happy meal set. The mandibular rejection and the zygomoplasty is together is like a set. uh, so yeah, patient went go to the clinics for the angle reduction, but the doctors recommend together is like a set menu. So yeah, a lot of patients had unwanted zygomoplasty. Yeah. So as I told you, I used the patient-specific plate for the zygoma repositions. Yeah, and this patient is complaint of the sagging after the zygoma surgery. So I repositioned her zygoma as original position. As you see, you can you see the sagging, the mandible sagging, the cheek is more tightened as the zygoma is elevation. So I can let's see. This is the after yeah, this is the before reconstruction. This is the after reconstruction. This before and after. The this is sag the cheek, the soft tissue is more tightened. So I see many cases after the face is more tightened and looks more young after zygoma repositions. So this is after, before, and after, before and after. You see this depressed area is well elevated. This girl is it is after the zygomoplasty. This is after repositions. This can you see? There's a sagged cheek area is tightened. Like as the mandible is augmented, is very well tightened. This is also right side is depressed and is very well augmented, and sagged cheek area is very tightened. And so revision orthognathic surgery. Yeah, I will tell you. Yeah, this yeah, this girl is too much mandible maxilla ups and too much the rotations, clockwise rotations. This is a pre-op. This is post-op. So too much ups and rotations. So this is my plan. But as you know, the mandible maxilla down is most unstable movement. So I designed this kind of the retaining retaining plate using titanium 3D printing. And these looms, I make these looms, and I augmented with iliac bones here. So this is before surgery. This is before revision surgery. This is after revision surgery. This is 3 years after revision surgery. It's very stable. This is 3 years after surgery. We can see the fully smile. We can see the teeth. Yeah, and she was very satisfied with the result. And if we using this kind of method, we cannot remove this hardware. So nowadays, I used only iliac bones. This girl also 22-year-old 22-year-old female, and she complained of the not showing the frontal teeth. The STO is total down 5 millimeters, advance 2 millimeters, the clockwise, counterclockwise rotation 2 millimeters, and some canting corrections. And this is the STO. And I used only the iliac block bone graft, the between the gaps, bones gap. And this is 1 year after surgery, and all of you know about the stability. This is before and after, before and after. Okay, see the I superimposed the 5 weeks after surgery and 1 year after surgery. It's very stable. Yeah, there is no movement. And also another cases I can see I saw the result is very stable. There is no change of the maxilla positions. Yeah, this is the 1 year after surgery, 1 year after surgery. Using this method, yeah, I using this only iliac bone graft. This is 5 millimeters down, and this is also 5 millimeters down. This is 4 millimeters down. This is 5 millimeters down. Yeah, and this is another very interesting case is this girl in state, she had too much counterclockwise rotations. So this is the initial photos, and in state, she had operation in states in using the artificial joint and too much counterclockwise rotations, and the occluder is also not good. And I think she want to clockwise rotations, but I don't want to remove this one and the yeah, I don't want to remove this one. So I did the SSRO and this situation. So this is before and after. Yeah, we can do. You can do. You can even the patient had a joint joint reconstructions, and we can SSRO. Yeah, we can SSRO. So I clockwise rotations more than 4 or 5 millimeters, and she is satisfied with the result because she before surgery she had the little really class 3 like appearance, but after that she's normal shapes. This before and after. And because of the time matter, so our the past some unimportant cases. And yeah, and usually in midfacial deficiency, I use this kind of augmentation, the onion bag method using PCL implant. This is after, this is before and after. The flat mid face is well augmented. So this is before and after. She really satisfied with the result. And this is 26-year-old. She is this is gender reassignment surgery, and she had already surgeries before. And my plan is clockwise rotations and advancement of chin can make her face more slender and more feminine. But because of the she had already this kind of surgery, is impossible to have a chin advancement. So yeah, I plan like this. So instead of a chin advancement, I augmented her chin with the onion bag method. This is before. There's more rotation after the surgery. So after the surgery, I also had the Zygoma reductions, and this is a more feminine face, I think. And I can do also the using onion method, the augmented of the paranasal augmentation also. Yeah, this is before and after. Yes. Okay, this is not important cases. So our pass it, and she complained of after the Tujo surgery. She complained of the double chins, and she want to restore get back to exactly same as the the before surgery. So I counterclockwise rotations and I reconstruct her mandible angle with a PCL. It also is well augmented. So this is a panoramic view, and this very well reconstructed uh, her mandible. Yeah, this from Malaysia and awful surgeries, and I did this. And yeah, and finally, this is my last topic. This is patient specific distractions. As you know, the distraction is a very good method for the reconstructed the mandible or maxilla, but there is some limitation of this, the distractions because of the vector controls and vector control. So I did the clinical trials. The actually it's impossible to make a patient specific distractor in every case. So I make a patient a specific distractor is a combining of ready-made distractors and patient specific bone fixation site. Okay. For example, you see these awful cases. I don't know why, and he had many surgeries, but the left mandible is fully resorpted and a very awful condition. And inside the mouth is also very difficult situations. And actually, at the first time, I planned only reconstruct the left mandible, but the uh, the 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 sleep study showed that the HI, the 47.2, RDI 60. So he had a really severe obstructive sleep apnea. So I should have advanced his maxilla and mandible. But for me, the SSRO in this right side is impossible. So I think yeah, let's do the distraction. But usually the distractor. So if I distraction, the direction it should be like this. But the ready-made distractor should only we can distract this area. So I design the bone fixation area like this, and we can fixation if we fixation like this, we can distract his mandible this direction. This is I make this one using the 3D printing titanium. So this is before. This is just I did it to two-stage operation. First, I SSRO. I did SSR split osteotomy, and I fixed this patient-specific distractor. This is ready-made. This is 3D printed. And after the distraction, I did 17 millimeters distractions, and then I removed. I planned the two-jaw surgeries and reconstruction surgery. So and after that, I augmented bone using this patient using the titanium meshes and the autogenous bone, and I reconstructed his left side with a titanium sintered bone. So this is before surgery. This is after surgery, and the airway is widened. Okay, because we can advance his mandible and maxilla together. So after the surgery, the RDI decreased to 10.4. Yeah, so I published these cases just maybe it yeah. So you can have a you can get some information about this patient. And this is the hemifacial microgyma patient. Actually, this case is not a revision surgeries. Yeah, he had a fossas, but very small conda. So I can do the tujo surgeries, but that I think I cannot well position of his right mandible. So I plan after the surgery, after I position his maxilla and mandible, and then I position his condyle using mandibular distractors. So this is immediately post-op and after distraction. So after I distract the 60 millimeters, so I can see his the occlusion is not so good. So and then after I 18 turns 9 millimeters distractions, his occlusion is very good because of I think the condylar part is going to the proper position. So because of that, the occlusion is good. So this is immediately post-op. This 60 millimeters turn is 9 millimeters turns. The condyle is more going back, so the proper position, the proper occlusions, and this is the proper occlusion. And then this is after tujo surgery of the distractions. And then I augmented the onion bank method using his iliac bone. This is before and after. This is before after. And this is before after this 1 year after the surgery. His the right mandible is really well regenerated, and this is before and after. And I think only two surgeries is impossible to get this kind of result. And we can put some titaniums and many bone cement or things like that, but I think the the best thing is patient own bone. So we have the solutions. Yeah, we have solutions. This is 1 year after surgery, and this is also I can uh, apply this patient specific distractions using this kind of method, because he worry about the mandible surgery. So we planned only maxilla surgery, and he worry about the VPI, velopharyngeal incompetence. So I planned the gradual maxillary distractions and the very accurate vector controls. So I want to just one surgery. I plan just one surgery, not another additional surgeries. So this is the surgery, and before and after. Yeah, before advanced 7.5 millimeters and elongation 2 millimeters. I designed this area to the exact vector controls. So yeah, so I did it with just one surgeries, and this occlusion is very good. And also this case is published. This is the final case. Also, this method can be used in the zygoma. He had a very depressed zygoma on left side. I plan to augment his zygoma with the distractions, and this is before and after distractions. I remove the distractors. I fix with the plate. So this is before the depression. This is after the surgery. Yeah. The conclusion is, if autogenous bone grafting is required in oral and maxillofacial lesions, the onion bank method using 3D printed PCL would be the good options. And I show you the many cases there, the regenerated bone is very stable, and we can make the bone very defined, very delicate designs. And the combined approach utilizing customized plate and ready-made distractors could be considered as one of the options in severe bone defect, weak bone structures, and extending the bone in desired direction. Yeah, is a problematic. This method can be used very well. Yeah, and I have a YouTube channels. I have YouTube channel. This is my YouTube. So there are many cases. Actually, is in Korean, but I think it's no problem to understand. Uh, and this is my email. If you have other additional questions, and if you have academical correspond communications, and if you have if you want to try this method, and I will help you. I will help you as as possible as I can. So you can send email to me, and sorry for the extended the lecture time. And thank you very much for listening this my lecture. Thank you very much.
Thank you very much, Professor Lee, for the talk. I don't think anyone was concerned about the time because the content was so amazing that we actually lost track of the time. So thank you so much for sharing your methods. So
Thank you
at
very
this
much.
time, I would like to invite Professor Saran and also Professor Watanabe for some panel discussion. And Professor Saran and Professor Watanabe, you can comment on some of your own experience or also ask Professor Lee for some clarification on his method as well. So first, I'd like to invite Professor Watanabe. Professor?
Yes. Thank you very much. My name is Watanabe from Tokyo Metropolitan Police, and I'm very impressed your presentation about, especially regarding about onion back method. Thank you. I have some. I have some questions.
Yes.
Yes, so I think the onion back method is very, very a good method. And when using the onion back method, do you need to make a slightly larger picture back with the expectation of bone resorption? So you mentioned in your presentation around, I think, 10% or 20% the resorption rate. Is that correct?
Actually, I think it's not a resorption. It's kind of contractions because
Contract.
yeah,
Contract.
because when I the put the bone graft materials into PCL implant,
Yeah.
I usually pressure it, but
Pressure.
there can be space between the bone
Okay.
graft materials. And as time goes by, the space is decreased, and I think it's condensation of the grafted materials. Because of that, there's a little bit decreased size. I tried as strong as possible. The pressure of the bone is very packed. So after if I pack the very strongly pack the bone, so the decreased rate is very small. I think if there is infections, the bone resorption is very severe. But without resorptions or the wound opening, I think the we can we cannot worry about can say we don't need to worry about the resorption rate.
Yeah, okay. Thank you very much. So I think the is it possible if you want to scrape or add some bones after the onion back method?
Scrape? What's the scrape?
Scrape, burr out.
You mean remove?
Yes.
Remove?
Yes. Remove or some burr out some bone. If the patient complained about, I think that my bone made by onion back method a little bit bigger. So please,
yeah. There are many patients.
Yeah, really.
There are so many patients. Yeah.
Yes, but because the patient
yeah.
expectation is very higher.
Yeah, that's
especially
right.
the patient.
Yeah, so you really, I think you have many experience. So yeah, there are many patients.
Yeah.
They actually firstly they told me that please reconstruct my bone as original, and after reconstruction they complain about this too much big. So, yeah, it can be easily grinded.
Okay,
Grinded.
okay.
Yeah, but it should be after at least the 6 months after surgery.
6 months, yes.
Yeah,
We
6
have to
months
wait.
after surgery. Yeah, wait. So and because of I had many chance to grind the bone,
Yeah.
so I got to know that the regenerated bone is the really good
Really
qualities.
good.
Yeah, and very strong enough.
Mhm.
Yeah, and it can be easily grinded, and
Grind.
and another good point of this method is can be added.
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 Put.
Yeah,
Yes.
some
Right.
patient complain of is too small.
Okay.
It can be added.
Yeah.
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 After the
Mhm.
firstly remove the PCL
Yeah.
first, and I harvested another bone from the iliac site, and
Mm.
using the
Mm.
another new shape of PCLs, I
Mm.
can be added.
Added.
Yeah, added. Yeah, adding is possible. Yeah.
Okay. So I'd like to ask one more. The PCR back, how long the PCR will resolved?
Yeah,
What?
very good questions.
Okay.
Actually, uh, may yeah, I have experience
Mhm.
to the during the
Yeah. Yeah.
grinding.
Mhm.
So some patient is after 6 months is after surgery, some patient is 2 years after surgery. So yeah, maybe at the 1 year after surgery, the PCL is very, how can I say, is very small pieces.
Yeah.
I can
Yeah.
see the very
Yes.
small pieces
Mhm.
is, and even after
Mhm.
5 years after surgery, I can
Mhm.
see the PCR.
Yeah.
Yeah, maybe I think it's more than 5 years,
5 years. Mhm.
5 years. But the great thing is that no problems till
Oh.
now.
Mhm.
The 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 PCL till
Mhm.
now, I think I put more than hundred of cases to put the PCL inside the
Mhm.
patient,
Yeah.
but there were no problems till
Oh.
now. Yeah,
Okay.
no problems, no infections, no
Mhm.
inflammations,
Mhm.
and no bone resorptions.
Mhm.
So PCL is very
Mhm.
stable and very safe, I think. And uh, and in FDA, the United States FDA, more than maybe the 50 years or 60 years is approved using the the suture materials, and
Yeah. Yeah.
the facelift
Yeah. Yeah.
materials. Yeah,
Thread drift.
yeah,
So I think one more question. I'm
yeah.
very curious about the post-operative risk of infection. Please tell
Ah,
us what you are careful about in
mm,
post-operative care, such as
yeah.
drain and
Mm,
compression and diet, rest,
mm,
antibiotics, etc., to
yeah,
prevent infection.
yeah. Till now, there were 4 cases of infections, only
Oh,
4 cases
oh,
infections, but each have reasons. The
mhm,
first one is there were some positional problems.
mhm.
I reposition the PCL.
Yeah,
So I think because of the additional procedure, because the next day of the surgery, I reposition the
yeah,
PCL. So
mhm,
make that causes the infections.
yeah.
And another case is I I I mixed with the too much alloplastic materials.
Uh,
Alloplastic material. So from then I don't put much of the alloplastic materials,
rest.
and so my know-how is I used the cetrazole irrigation.
Mm,
Cetrazole is antibiotics.
yeah, yeah.
Cetrazole irrigations.
Irrigation.
Irrigation, the antibiotics irrigations after the surgery, during the surgeries,
Yes.
and before the day before the surgery, I order patient have the scaling
Ah, yeah.
because of the scaling. Yeah, scaling
Mhm,
the inside the bacterial
mhm.
should be the reduce the inside the
Yeah, yeah.
bacterial. Yeah, and I shoot myself. I I mean,
Who
my
yourself?
resident. I do not
Let them.
yeah, order my resident to the suture. I do the surgery. I suture myself,
Ah, yeah.
and I don't use the continuous sutures.
Yeah, yeah.
I don't use continuous suture. I use the interrupted sutures. I think
Yeah.
suture is very important.
Mhm.
Suture is very important. I don't use the drain.
Drain. Oh,
I
you
don't use the drain.
okay,
Yeah,
just
yeah.
compress.
Yeah, compressed. Yeah.
Yes.
Mm,
How
mm.
long? Compress.
Compressed maybe 7 days.
7
7
days.
days. Yeah. Mm.
Okay. How about the diet? When the patient has
Diet.
diet?
I think diet is I told patient you can eat whatever you want.
Oh, great.
Yeah, yeah. Not smoking. Yeah.
Okay.
Yeah.
So I want to have more question, but the time is limited. So
Yeah.
yes, thank you very much.
Yeah. You can do my email. So okay.
Yes, thank you very
Yeah.
much.
Yeah.
Thank
Yes.
you, Professor Watanabe.
Yeah.
And now I'd like to invite Professor Saran.
All right. So thank you very much, Professor Lee. I'm Dr. Salan from Thailand. I'm plastic surgeon and
Stuff. Yeah.
yeah, sorry.
Yeah.
Thank you for a wonderful presentation and many case is very, very beautiful. And
Thank you.
I just ask you about one or two questions. The first one, I curious about the soft tissue prediction when you do the revision case in the orthognathic case. You can make the 3D panning by many software, but in the facial contouring, or how do you predict the soft tissue change? How do you make the high satisfaction for the patient?
Okay, thank you, thank you. Yeah, this is very challenging. Yeah, this is very challenging, and so I like the patient want to restore exactly same as original shape because we can see the original CT scans and we can design exactly same as the original shapes. But some patient want to the between now and the original cases at that time it's very difficult to the predict. For example, in mandibular angle area, so patient want the definite line of mandibular angles, but patient don't want big, don't want to widen. So it's very difficult to design the mandibular shape. So actually, at the time, uh, mm, I think it depends on the patient desire. Okay, so I think in my experience, patient is more stressful when the reconstructed bone is bigger than they expected. Usually, yeah, there are two. Yeah, if there is an optimal size and another, yeah, is very good to the reconstruct the optimal size. But we can the less than the smaller than optimal size and the bigger than optimal size. So I think in my experience, patient stress they are bigger than optimal size. So I designed a little bit smaller. Yeah, yeah. If the patient complain of the is smaller, and we can add, and also patient complain of bigger, we can grind. But I think the patient more stressful in the bigger state. So I little bit design the smaller uh, and uh, and and the and this depression, a lot of patients want to manage the depression of this mandibular body area. So and during the PCL, the one of the great characteristics of PCL is I can manage it during the operation. Yeah. So if I put the design, the plan the PCL here, if the still there is a depression, I can add more bones, more than planned. So I can see the patient the shapes. If there is a still depressions, I can put more. I can put more. So
Okay.
yeah, so I can manage it during the operation. So actually, it's difficult to predict everything. So we can respond in during the operations, and we can respond after the surgery. Yeah, so we should explain to patient before surgery. Yeah, for example, your angle can be bigger or smaller than you expected. You can need one more surgery. So all of my patient understand the additional operation can be necessary. So yeah, so I think, yeah, prediction is very important. Yeah, we can I will, yeah, do my best to predict the best result. But till now, yeah, I think during the operation and after the operation, the respond, the patient reaction is very important.
Yeah, yes, very nice, because I saw many of your cases very beautiful and
Thank you.
very nice. Thank you very much.
Kokunka.
ขอบคุณครับ
Thank you, Professor Saran. Last but not least, I'd like to invite Professor Low for some comments.
Yes, Dr. Lee, I'm quite amazed. Amazing result. Very impressive to see your result. And
Thank you very much.
just like to ask the question. I'm not very sure. You said PCL is printed like a cage, and then you put the bone graft from iliac crest. And do you put any additional like factor like something like morphogenic protein?
Yes, that's right. That's right, Professor Low. Yeah, I usually, I think every cases I cannot harvest enough bone from iliac crest. I added the allograft, oragraft. Usually I use the oragraft, and sometimes some alloplastic materials, and I mixed with the BMP2, BMP. Yeah, at I try. So in some cases, I wanted to see the difference between the using BMP2 or without BMP2. I some cases I didn't use the BMP2, so the bone regeneration is really poor. Yeah, I saw the some cases without BMP2, the result was not good. So nowadays, I always mixed with the bone graft materials with the BMP2.
Okay. Yes, that's why I thought that there must be some help from the bone morphogenic protein.
Yeah, that's right.
The other question is that since a lot of secondary cases, it is additive surgery, meaning that it's depression, too much bone resected in the ankle area, the lower mandibular body area, or in the zygoma area. How do you compare this with your method with other kind of implant? There's also a lot of commercial implant, even the so-called the pre-med implant that can be used, such as Medpro or other allograft. But how do you see the difference between your result, your method, and the implant?
Okay. I think the patient specific the materials can be 3D printed is best for the patient, because in during surgery the carving, for example, the Medipore is not can be 3D printed, so we can carving and we can position. But as you know, the during the surgery, we just see the inside the mandible only this amount of incision, so it's very difficult to position the proper positions. And so I think we should use the guide, and I always use the guide. Even I use the guide. Sometimes I position the wrong position. That's one of the challenging of this method. And I think the 3D should be 3D printed, and we should make the guide. So that's why I don't use the ready-made implant. And ready-made implant sometimes is very difficult to maximum bone context. Is not patient specific maximum bone context. So I don't use there is a limitation of the materials cannot be 3D printed. And the titanium, we can use the titanium 3D printed implant, but the problem is that uh, the Korea is very in winter is very cold. Some patient had a very the very 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 cold, feel very cold their mandible after the titanium implant inside.
Mm.
And mm, and a lot of patients in Korea had the laser treatment, for example, Somaji, Ulcera, and things like that. The laser treatment, and some clinics do not give the laser treatment to the patient who have the titanium inside uh, their body. So, and if there's a big implant, titanium implant here, and if the patient had a problems on necks or the brains, when they have the CT scans and the MRI, there are a lot of the artifacts can be produced because of the implant. And the and before I said, and the prediction is really difficult. If I use the titanium or another PEEK or bone cement, if the patient complain about the size is big, too big or too small, it should be removed and changed. And I think is one of the best characteristics of the onion bag method. Onion method can be grinded and can be added, and some patients have something the foreign body sensation after the titanium or bone cement, but the patient who had an onion bag method never had such a complaint of the foreign body sensation. So I think
Okay.
in in main point of view, the original their own bone, using own bone is best method, but there is a donor site, can be donor site morbidity, there is a scars. And I have one case is the nerve damage, the LFC and lateral femoral, what's that?
Cutaneous nerve,
Yeah, cutaneous. Yeah,
Yeah.
it's a damage
Okay,
cases. Yeah.
it's a very nice result, and I'm very interested to see your result. Congratulations, very wonderful result.
Thank you very much.
Thank you, Professor Low. That's the end of our panel discussion, and we'll move on to our Q&A session. So for Q&A session, both Professor Honda and I have questions about the amount of bone graft that you need for the onion bag method. How do you estimate, or do you usually just harvest a certain amount?
During design, I can estimate the exact amount of bone volume. So usually I can estimate. I can estimate the bone volume, needed bone volume. I can know. Yeah.
Is there
So
like a maximum amount that you can
maximum amount. I
that
think maybe 12 cc. I think 12 or 12 till now. Actually, is the patient iliac the volume is very important. So I can I can the I can say I can touch the patient iliac site, so I can estimate the thick the volume of the patient the iliac crest. So I grade it to the 1, 2, 3, 4, 5. Yeah, usually the average patient have the 3 or 2, 3 or 4, 3 or 4. So if the patient have the big iliac site, maybe 12 to 15 cc is possible, and I can add more than 5 or 6 cc's of aura graft. So I can harvest maybe 10 or 12 cc's of bone from Zygoma from the iliac site. So I think the maximum is the maximum is maybe 15 cc. I think 15 cc. Yeah, 50 cc is really big amount of the reconstructed volume.
And would you say that if anything greater than 15 cc's, then you would do the distraction method instead?
Yeah, maybe we can do the second stage, and some patient have the this angle area reconstruction, and then after 6 months after this operation, patient wanted to please reconstruct my chin again. So at the time I harvest upon the same site, and I can see the more than 50% of the harvested bone is regenerated. So I can harvest again. And some patient ask me, please use both side of iliac is no problem. But till now, I didn't use the both side of iliac site at once. So maybe you can use the two stage method. And if the the patient iliac site is very small and the amount of the reconstruct volume is really large, maybe I can use the titanium or another materials.
Okay, thank you. And our next question is from Dr. Rana. And then the question is that for your distractor that you use, I know that you print out the patient-specific plates, but then for the distractors, what is the name of the distractor that you use?
Aha. Okay. For mandible, this is for maxilla. This is a cherry. Can you see my? Can you see my?
You can share.
Yeah.
Share the style. Yeah.
Oh, we can't see right now, but you can share the slide.
Can I share?
Yes.
Yes.
Okay.
Yes.
Okay. For the maxillary distractor is very widely used distractor. This is brand name is Martin. And distractor. Do you know Jail? Jail is a Korean company. It's a Jail mandibular distractor. Is very cheap, cheaper than the from Martins or Strikers. Is very cheap. Yeah, if we want this distractor, yeah, I can manage. You can get this one. Yeah, I can manage.
Yeah, so for the audience, if you need the name of the distractor or access to the distractor, please email Professor Lee for more
Yeah, no problem.
information.
Yeah.
Okay, and I think that's the end of our Q&A session. So PY.
Thank you. Thank you, Uilyong. Thank you for your very amazing and very knowledge sharing. You really broaden our visions in the three-dimensional printing in the materially. As I know, Korea is a very amazing country because like the manifold shaping, the Zygoma reduction, Korea is always the leader in Asia. But you are the one to go back to reconstruct those who are now with the good result. So you are still the pioneer to reconstruct the failed cases. So far, the one I know, the guy can do a very nice outcome. And you have very nice knowledge, and you want to do the density and the volume to validate your onion back the method, the bone, the regeneration is quite good. And as I know, you are very nice because in your very beginning, you are a clamp surgeon, right? You go to several the international clamp mission and to share your knowledge for those who in need. One more thing is that IRB approval in Japan and in Taiwan is always not easy to be obtained compared to Korean. So seriously, your story and your achievements really amaze us, our visions as well. Of course, finally, your email should be always impressed in the ICC's Facebook, and I will let our audience know they can easy to get you in the email contact. All right.
Sure. Yeah.
You will be very busy, I believe.
No. Yeah.
Okay, finally, I would like to invite all our participants and to show you a smile, and we need a group photo with today's our speaker, Professor Lee. Allow me to introduce our next, the ICC webinar. The October is quite busy for ICC because we have a weekly webinar here. And as you know, we have some friends already arrived in Taiwan because we have 3 in row the day for annual Chang Forum since tomorrow. So we will be free in October. So our next topic will be the November 2nd by Professor Pramila, and her topic is cleft care at the Nipple Cleft and the Burn Center. Okay, looking forward to it. And I will count to 3, and please give me a big smile. Okay, please. And thank you, our panelists, Professor Sarang from Bangkok, Professor Watanabe, for your very nice question, because all of your question is what I want to ask to Professor Lee. Thank you very much. Okay, 1, 2, cheers. Okay, thank you so much. And once again, good morning and good evening, and thank you, Professor Lee, for your unlimited sharing your knowledge. Have a good day and have a good night. See you. Bye-bye.
Thank you very much.
Thank you again.
Thank you.
Thank you. Bye bye.
Thank you. Thank you, Watanabe. Thank you. Thank you, Sarah.
Welcome.
Thank you, EK.
you.
See you soon.
See you.
Thank you, Yaya. OK， 好，我们先下线，然后再上来一次好了。如果我们要录一个小段的话。OK，Thank you, Junior.
Bye bye. Bye bye.
OK， 拜拜拜拜。Thank you, Professor Lee.
Yeah.
Bye-bye.
Please send me the group photos.
Oh, no problem. I will give
Okay.
you the real one. Yeah,
Okay.
email to you the home address. Okay. Thank you very much,
you.
Uilyong.
Good night.
Bye. Good night.